The Killer Growth Podcast starts now.
What's up, guys? Sam here with the Killer Growth Podcast. Today I have Brandon Alleman with Antioch Direct Primary Care.
Yep.
But just Antioch Med.
Antioch Med.
That's easy to say. I like saying Antioch Med.
Yeah.
But thanks for being here.
Yeah, I'm excited.
Made the big journey from Wichita.
It's a great drive.
Yeah.
I was joking when you have 4 kids at home, a 30-minute drive alone is, great.
I go to Wichita a couple days a week, and I'm not going to lie, I enjoy the ride there and the ride home.
Yeah.
You can get work done, podcasts, catch up on my podcasts. I'm still behind on our podcasts. But great. So you've not listened to an episode, so we start with a nice.
Apologize.
No, don't apologize. You're going to listen to this one, I hope.
Actually, I don't think I've ever listened to myself on a podcast afterwards.
You just gotta
maybe I'll listen to the other ones.
There you go. Perfect. So we just start out with an easy. We'd love to know your story of like when did you become a doctor, and then what led you into Antioch?
Sure. Stop me if I go too far back. But,
you got it. I'm good at interrupting.
No, in college, I actually majored in math and physics. And so I finished those degrees in 3 years and then took a kind of semi-medical mission trip to Africa between my junior and senior year.
Wait, so you got 2 degrees in 3 years?
Yes, finished those coursework in 3 years. And so between junior and senior year, took this trip to Africa. We were doing kind of AIDS education. And so I came back from that trip and had a summer job working at the particle accelerator at Michigan State. And it was fun. I got the program. I got to learn C++. It was fun stuff, but I was like, nobody cares about this. I mean, a very small...
Did you not care about it either?
I cared about it, but a very small subset of the people in the world understood or cared about this. My brother now works at the particle accelerator at Michigan State, so it's nothing wrong with that work. But it was just the juxtaposition of those things. They're like, I like science. I'm good at these things. Is there a way to use that in a different role? So I decided to go to med school my senior year. So took all my prereqs my senior year. Actually had a year in between undergrad and med school. Did a Fulbright Scholarship in Eastern Europe, and then
you said Fulbright
Scholarship. Yeah. Okay. So it's a exchange program. So either teachers or scholars can do a year abroad, and then countries send people to the United States as well. So then applied for med school. I was there. Didn't know if I would like clinical care or not. So wound up doing the MD PhD program. So combines getting MD with getting your PhD. Okay. So did 2 years of med school, 3 years of PhD work, 2 years of med school, and then made the decision kind of as I went through, I liked clinical work more and more and took some classes just on healthcare systems and healthcare quality. And I was like, I'm actually going to go into primary care, which is kind of unheard of going through the MD PhD program. I think I was the only one.
What was your draw? Why?
I heard about the type of practice we do in medical school and knew probably if I was going to practice clinically, it would probably be in something like that.
Okay.
I'm not great at having bosses. And so I knew I'd probably want to do something that I had a little bit more control in and knew that, are we doing a good job in taking care of medicine? I think lots of medicine now it's easy to feel like you're a cog in a machine, and I didn't want that.
Truck.
That's the truck.
Yeah.
I got
distracted. Real loud.
So that's been my journey to medicine. So, chose to go into family medicine. Yeah, I think I was the only MD PhD student to match into family medicine in the country that year. Came to Wichita for residency training, and then opened our practice right after while I was in residency. So.
And was the practice direct primary care immediately?
Yes,
it was. You went right in. So let's talk about that. Like, why direct primary care?
Yeah,
because it was happening. Like I Atlas MD was already there. I remember when you guys opened.
Yeah, we were not the first. There were probably a couple hundred other practices in the country, so we didn't.
Which is still not a lot.
Yeah, we didn't come up with the idea for sure, but I started medical school with my co-founder Nick Thompson, and so we met at Iowa. He came to this program. He got 3 years ahead of me because I did the PhD work, so he was kind of exiting residency as I was entering. he did some international work, kind of moonlit for a while. And then together we decided yeah, this is the type of practice that, if we're going to take care of people, this aligns our incentives best with our patients, if that makes sense.
Yeah.
So that's something we talk about a lot is why direct primary care. Lots of people do it for lots of reasons. To me, it best aligns our incentives with taking care of patients. And so that's our main focus. And it's just led to some other areas to affect medicine as a whole. So,
yeah. Take me through that moment or your decision-making. Were you familiar with DPC the whole time? You were like in residency?
So in medical school, our family medicine textbook had this blurb at the back, and it was about a doctor in North Carolina that did this thing, did this different practice. And that just really resonated with me. I don't know how much you know about medicine, but a traditional...
I know the appropriate amount of ibuprofen to take.
That's good. That's a great place to start. But a traditional outpatient physician or traditional any physician, they're what's called fee-for-service. So somebody has to come see them. They have to code the visit according to this coding thing, and then usually a third party determines how much that code is worth.
Gotcha.
And so,
insurance.
Yes. Yeah.
Okay.
Usually an insurer of some kind. That leads to some perverse incentives. So
Sure.
the most common outpatient codes for a family med doctor are 992 and 3 to 992 and 4. So moderately complex visit 992 and 3, slightly more complex visit 992 and 4. And I've assigned how much those are worth. That's not really what patients need. Patients don't come in and say, I'm a 992 and 4. They say, I have these problems that I want solved, and I want to work out with somebody to solve them. If I can only make so much on a 992 and 4, I have to put that 992 and 4 in a certain time spot, and I see that many 992 and 4s or 992 and 3s a day. Well, I got to see 25 of those a day or more to meet my overhead and pay myself a salary. So I care as a physician in the fee-for-service system of getting people in and out. That's not what people want when they interact with a healthcare provider. So this was a way for us to say, hey, if we change the payment model, it changes how we can deliver care.
What's the ratio? I mean, 25 a day, that seems like a lot of people.
That's on the low end. So
what's the high end?
The high end's probably 40 a day. But the average face time you get with a primary care physician at a normal fee-for-service visit is about 8 minutes. You may interact with MA, you may interact with a nurse, but the time I get to spend with my doctor is tell me your one problem. And
you spend more time with the nurse.
Yeah.
In that model, I would agree.
And tell me that one problem. We'll address that. Don't say anything else because I don't have time for it. Make another visit because then I can bill you again, right? If you come back. So again, I don't think doctors are doing that malevolently.
Sure.
That's just the system they're given, and that's the system they have to work within. And I think that's why you see not many people going into primary care, and why you see burnout very, very high in the profession as well. So.
Interesting. Burnout. So you don't see a lot of people going into direct primary care, or you see more people going into...
Yeah. So from a couple hundred clinics when we started, now there's over 3,000. So direct primary care certainly over the last 10 years has become much more popular, and new clinics are opening all the time. So I think that's somewhat revitalizing interest in primary care. Everybody's incentives are different for choosing DPC, and we can talk about that a little bit. But yes, I think that's a little bit revitalizing. This is a new way to practice medicine, but the vast majority of physicians and patients are still seen in a fee-for-service setting and still getting kind of the lowest common denominator care.
Yeah.
So,
take me through the business model a little bit, if you're good with that.
Yeah.
So it's a subscription-based. I think that's what a lot of people see, and when I've talked to people about it, because we've done it for probably 8 years now with you guys.
Yeah. You can say that. I can't say that. So.
Right. Yeah. You're like, yes, you said it first. Don't tell them everything, okay? In that model, I think a lot of people go, oh, it's just another monthly fee once I understand what it is. But that model in my mind, day one, like how do you make that work? Because what were you charging 10 years ago per adult and per kid?
Yeah.
Because it was pretty low.
Yeah, we were, I think we started out at $40 an adult and $10 a child.
Yeah, it was.
We were not very good business people back then.
Sure.
And I think the business model, you referenced another clinic, so I'll reference another podcast if that's okay.
Great.
Most people have probably heard of the Acquired podcast.
Yep.
But if you've listened to the Costco episode of the Acquired podcast, we functionally have the exact same business model, right?
Interesting.
So Costco doesn't lose money on anything they sell, right? But their margins on what they sell are much lower than what Dillon sells, right? So they sell you a huge thing of almonds. It's very inexpensive, but you have to have a membership to get in the door.
But I pay $150 a year or whatever it is.
So you have the same thing. So your membership gets you in the door. It gets you access to your physician. And then as many problems as we can solve within our walls for our patients, we try to solve within our walls for our patients.
Yeah.
So along with the membership, you get the physician. You get the physician that you can call after hours. You get the physician that you can text during hours. You get the physician that's going to see you that day if that's what you need. You get the physician that's going to stitch your kid up if that's what they need. But along with that, we solve other problems in healthcare as well. So that's kind of the business model, if that makes sense.
Yeah, it does. Talk about the start of it, though. Like, how long did it take? I mean, were you guys moonlighting? Did you just?
So our startup costs. So kind of history. I was beginning my third year, or in my second year residence. I went to Nick Thompson, Dr. Nick, and said like, "Hey, we should do this type of clinic." You could ask him about this. He had originally thought like, that's a really dumb idea, but he kind of did his own research and he's like, no, actually, I think this will work.
Yeah.
So we started, and yes, didn't pay ourselves anything from the business for at least 2 years. So we were moonlighting, but we put only about $30,000 of capital and then never any debt in the business.
Gotcha.
So moonlit on the side at rural ERs and residency and things like that to kind of fund ourselves while the business grew.
Okay.
Yeah. And so Nick took all the patients year one because I was still in residency. I did a lot of the payroll and back-end and accounting and things like that. And then I joined clinically right after residency. So,
yeah. Overall, that model, like building a business like that, is so different than setting up. Because if you were to set up a residency or a practice in a hospital, how does that model work? Like doctor says, because I know like you can lease a space at a hospital, or you do like a profit sharing, or you work for the hospital. Break that.
Almost no new independent primary care practices are starting. So if a primary care physician is going to be working in the traditional system, they're either joining an existing practice or they're joining a hospital system that's functionally an existing practice. So
Got it.
I don't know of I know of several primary care offices in the Kansas area that have been assumed by hospital systems, but no one is starting their own business and choosing to be fee for service. So all of the new independent practices are more clinics like ours than anything. So
is there other versions of DPC out there? Like your models are different variations of it?
There's a little bit. Some people are hybrid. Some people will still bill Medicare a little bit and do DPC for non-Medicare patients. I think oftentimes we get assumed we're concierge medicine. And so the history of that might be a little bit useful.
Yeah.
We push back against that term. We certainly think you get concierge service at our office. Concierge medicine from the 80s and 90s was kind of double dipping. So I would still bill you fee for service for all the medical things, but I wanted a lower patient panel, so I'd just charge a retainer to get access to me. Oh. So that's the biggest difference between concierge and direct primary care. So we are not concierge. We are not contracted with any insurance company to deliver care. All of our things are based on membership. So I don't know if I answered your question, but we can.
No, it's great. Actually, that's really interesting. So like back in the day, then was that just this doctor's that good? Here's my retainer if you want access, and I do insurance, and I don't want to see as many people.
Right. So I had a fancier office. I got a cup of coffee when I walked in. Right. The concierge was the experience, and I
wish Tyler handed me a cup of coffee when I walked in.
And it's a way to add extra revenue that isn't the medical side.
Got it.
We don't. That double dipping just isn't kind of what we're going for. In our model, we get to take care of a broad range of people. So we take care of individuals, we take care of people from businesses, we do a lot of different things. So we're not concierge medicine. Most of DPC is that some people try to do a hybrid practice, bill some insurance, don't. There are very few like that. Those are just confusing to run, and it's easy to get yourself in trouble doing the wrong thing or billing the patient the wrong thing. So we've been pure DPC from the beginning.
Okay. So you said there's 3,000 of them now. So I feel like the majority of people I talk to aren't in
Still don't know.
DPC
Yeah.
or they have no, and then I like try and explain it. But if you're saying those aren't opening, so they're still existing. So is the education, like when people are going through residency, is it biased towards pushing them towards a hospital and an existing practice?
So I think Nick and I were a little bit unique in that me going through the MD PhD program, I didn't have any debt coming out of medical school. And Nick, with kind of moonlighting and things, was able to pay down debt very quickly. I think most people coming out of school are looking at $200,000 to $300,000 worth of debt and saying, I need a job that's going to pay me a salary so I can do this. And
a lot of hospitals, they'll negotiate contracts with debt on the school. Is that
so?
Still
Sometimes it'll be a signing bonus. Sometimes it'll be loan repayment. Sometimes it'll be things like that. But yeah, while people may start medical school very idealistic, that gets beat out of you in these 7 years of training. And so you come out of residency, you're tired, and you're like, well, I just want somebody to pay me money.
8 to 5. Yeah.
So our goal in growing is we want to provide a better place for physicians to practice and then allow people to get better primary care as well.
Are you looking, because obviously finding doctors is a big part of this that fit your model.
Yeah. We're hiring. Yes.
All the time.
Send them
Let's
our
way. Are you around students quite a bit? Like, are you looking for people coming out of residency, or are you looking for people that are already had some experience that have been at a practice?
Both can work.
Okay.
We've done both. Three of our physicians practiced a little while in fee-for-service and then kind of joined direct primary care after that experience. 3 of our physicians came right out of residency doing that. So it's both. But I think that's on the physician side. I think you were asking about the patient side as well.
So I'm just curious if it's exploding and there's 3,000 clinics now and there's only 200 10 years ago, right? Where it's over 10x.
But when you look at the number of providers total, that's still not a large number.
Got it.
If that makes sense.
Yeah, that does make sense.
It's a large increase over what used to exist. The vast majority of care is still delivered in the old system.
So let's talk about, because you love to talk about insurance. Let's talk about health insurance combined with DPC. Yeah. I feel like everyone loves talking about health insurance. So like break that down for me, because that was the model as a self-employed person that was just a no-brainer with kids, right? Okay, I'm going to pay, I don't know what we pay now. Is it 25? How much are kids now?
An individual child membership's $39 a month.
$39. So I pay $39 a month and I get unlimited primary care to my kid, right? And as in we can text Dr. Nick and email Dr. Nick and show up when we need to and get the proper care. So like with kids, life-changing, right? Like that's what I tell anybody. Like if you have young kids, I mean, the amount of emergency room visits we've been saved by Dr. Nick, like it's, I should have counted that. That would have been a good case study. How many times would have I gone, which we did go before, to like, we probably have gone once.
And we track that a little bit, the number of after hours calls we get. If you assume a certain percentage of those would have been urgent care ER visits, we are saving the system a lot of unnecessary care for those things. Yeah.
So that allowed us to think more strategic about our health insurance, knowing we had access to that. We weren't as worried about our deductible. So what is and I feel like anytime I've talked to you, you're always like, it's like this unicorn you're trying to, you're packaging it together. You're always thinking through what is the perfect combination.
Sure. I think people don't understand health insurance, and health insurance doesn't work like any other insurance you're used to. And so I can't remember if I've said this to you before, but I haven't said this to you on camera before. I do a little thought experiment. And so you have homeowners insurance, right? You own a home. When do you expect to use your homeowners insurance?
In a disaster.
Right. You really never want to use your homeowner insurance. We've somehow equated health insurance, instead of like, hey, I should use this when something really bad happens, to I have to have this thing in order to access any care. And so we would never think about that with our car either. So car insurance, I'm only planning to use this if my car's like totaled. If my car has to be towed away, I'm planning to use my car insurance. If you get a chip on your windshield, are you taking that? Are you running that through your auto insurance? Almost never, right?
Yeah.
So we've trained people the wrong way with health insurance to think like I have to have this in order to access care, and the system is then built around that. Really, for something to be an insurable event, it has to meet 2 criteria. It has to be rare and it has to be like financially catastrophic.
Yeah.
When your kid gets a cough, is that rare?
No.
Is it financially catastrophic?
Right. No.
No. So it shouldn't be insured, right?
Yeah.
So I think that's what people need to start with is like, I should really only be using insurance when it's an unexpected event that is really expensive.
Yeah.
Even something like getting an ACL repair, the cost of an ACL repair is like $8,000. That is less than most people's car. Most people don't use their auto insurance to purchase a new car, right? They plan for this and they fund it. And an ACL repair is not something that has to be done like tomorrow or you'll die. It's something that's done over weeks. So I think just the way we've approached insurance has led to, well, now care has to fit in this box, and care then is the lowest common denominator care. So if you fix the way we deliver care, insurance can then be over here on the side. I should have accessible care for lots of the things I need. I should be able to pay a little to protect myself against the unknowns. I think the other thing is that most bankruptcies have a healthcare component to them. And so even people who are insured, it's not even protecting them from the thing that is supposed to be protecting them. It's not protecting them financially. So yeah, the whole space of how we've chosen to insure health in our country is just like, it's perversely incentivized. So
Yeah. That's a really good take. No, you've not said that before. That's a really
Yeah.
good
So there
analogy.
are ways to fix that.
Yeah.
But
So break that down for me. Today? So let's just talk about somebody has a job, right? So for example, and you and I talked about this.
Yeah.
My wife just started working at the nursing
Yeah.
program at Butler, right? And she got insurance,
Benefits.
and I said, I verbatim, I don't know if you remember this. I said, yeah, she got great insurance. You go, well, I don't know if it's great. But break that down. Someone's working somewhere and they think they have great insurance. Why go DPC
Yeah.
if they feel like they've already got a great setup?
I think what people don't see is what's taken out of their paycheck. So
Sure.
if you work at let's say you work at a 100-person company, what do you think the average premium cost for an insurance plan is for somebody who's fully insured at a 100-person company for a family?
For a whole family?
Yeah, for the year.
For the year?
Yeah.
25, 35 grand?
Yeah, so like $27,000.
Okay.
So would you rather have that money in cash and you figure out your own insurance, or would you rather pay for a Blue Cross card in your pocket, right?
Which they don't normally do, right?
So the tax structures don't often allow them to,
Take
because if
the
they give it to you
cash.
as cash, you have to pay taxes on
Exactly.
it. If they give it to an insurance company, it's a tax-free
No, I would
contribution
rather.
to you.
Yeah, I mean, it makes sense if I knew there was an option, or I knew where to go, or I knew where to start.
Yeah.
That'd be one thing.
Yeah.
It's like even knowing that I could find something better, or even just the headache of nobody wants to go
Right.
figure that out.
But I think
they're you.
But I think what's really happening is because we've tied. That's another thing that doesn't have to be this way, but currently is that way. The tax incentive for a business to provide the healthcare for its employees means that has to happen. What's really happening is those 100 people are taking functionally $300,000 a year and handing it to an HR person and saying, spend this money well. Does that HR person, is that person an expert in healthcare?
Probably not.
No, not at all. And so there's this term in a book, they call this proxy buyers, right? So employees have turned their employers into proxy buyers for their healthcare when that is not their expertise. If you want to further follow the incentives, so I'm a CFO and then the HR person, and I have to pick healthcare. Well, if you don't know what you're doing, what do you do next? Like if your car breaks down, who do you go to?
Yeah, mechanic.
You go to a mechanic. So you go to an expert.
insurance broker. Yeah.
So an insurance broker, and some of them are great. A lot of them, they are oftentimes paid on a commission if they're selling you Blue Cross. So if your insurance gets more expensive, does the broker make more or less money?
I'd assume more.
Makes more money.
Percentage.
So a lot of the incentives are, even this expert who's helping them, there's not a ton of incentives to drive you to the right cost. It's drive you to what's easy, renewable, and I get paid. And when $27,000 a year is going towards just the premium, well, then I don't want to get any care because I've already spent all this money, right? I'm not going to do DPC because I'm already spending this money. My money's already been spent on something that's low quality. There's this shift. So what we've done, and we're probably as deep as anyone into this, of partnering with businesses to say, hey, when you have like all of this easy care accessible, build a plan around this. If all of this care is accessible, you can pay a lot less for the insurance side when we can solve all these problems on the primary care side. So we've partnered with several medium to large size companies to kind of redo their health plan around this type of primary care. And that makes all the other downstream decisions easier, if that makes sense.
Yeah, no, it does. So walk me through that. I'm curious because that's almost like a lead funnel for you on the direct primary care side, but then you're also helping them with the insurance side. So do you have a brokerage or a brokerage you prefer or refer when you're putting these things together?
We've done in the past, we've done some of it ourselves.
Okay.
We are working now more in partnering with people who, as they see costs going up and up and up, employers are coming to them and say, hey, we need better solutions than this. We can't just keep paying 10% more a year. 2026 has been some of the highest healthcare increases ever. So people are now looking to solutions. Well, now if I get this bundle of care for a fixed price at a much lower cost, it allows me to be creative with the other things I do. You're starting to see specialists do this as well and being transparent in their prices. So what this allows, you take that. I guess maybe going back to this a little bit. So that 100-person company, on average, a business is going to spend about $10,000 per employee per year on their care. So that's $1 million, right? So it allows them to take that $1 million and buy healthcare at the right price for the common things. So your colonoscopies, your MRIs, your primary care, your sutures, even up to a knee replacement, right? Those are all steerable, known cost things. Well, if I'm doing all that at the right price, not going through insurance for those things, I can spend much less on just the rare things, on the cancers and the car accidents and the things like that. So you get people way better care by picking this type of primary care, right? Because most of the people, they're so scared of their deductible and their copay, I'm just going to avoid care until I have to go to the ER, right?
I think that's very real.
So as the business, if I make a different decision, I can get my people way more for less money is the goal. So,
yeah. So value, so savings, but then also better care is the ultimate goal.
Value is the right term.
Value, because you're not saying like, hey, this is cheaper, and I promise it's better.
Yeah.
You lead with cheap. It
is this strange thing. It's like you're telling me I'm going to save money and I'm going to get something that's a way better experience, and the answer is yes. And people just don't believe you when you tell them that.
No.
But the people who have experienced it, they usually don't go back, if that makes sense.
So I'm curious on when you have kids, and Haley and I have talked about this. Like if you just got two adults, they have no kids, and they go once a year to the doctor. What your DPC percentage? I'm curious how much of it's like family versus just single adults or couples.
We're a little bit weird in that sense. So because we do some extra things, so Dr. Elson does a lot of women's health. I still do obstetrics. Dr. Nick used to do obstetrics. Deliver babies.
Oh, gotcha.
Most DPCs are around 10 to 15% pediatrics. We are much higher. We're like 30% pediatrics.
Okay.
So our families and peds are higher than most. But we're about 70% adult, 30% pediatrics.
So I was wrong in my assumption. My assumption was the majority of your members would be kids, like pediatrics.
Oh, no.
Interesting.
Most of them are adults.
Yeah.
And so that comes from individuals. So I think of us as taking care of kind of three buckets of people. Some are uninsured, right? They, for whatever reason, they own their own business. They're uninsured in the eyes of the traditional healthcare system, but they see us as like, well, I'm late 40s, early 50s. I know I have healthcare problems. I know I'm going to need medications. I know I'm going to need labs. Hey, I can get all this through Antioch for a known cost. I didn't go into this, but everybody is usually aware of like cost plus drugs now. And I think that's a great resource.
Mark Cuban.
We have 200 drugs that are all cheaper than his, if that makes sense. So when you become a member, you have access to those medications that are less. If you go and get a lab test through your insurance, the five most common labs are a CMP, an A1C, a thyroid test, a blood count, and a lipid panel. Oftentimes people go get that done their insurance, and what they're paying out of pocket is a couple $100, right? Just even towards their deductible. In Antioch, those 5 tests are like $40.
Yeah.
So we're building other things in that the membership's more valuable for that as well. So we get a lot of people in that bucket of uninsured, but I know the cost of everything. we then have the business bucket. So we take care of about 70 businesses in Wichita, or in the Wichita and the surrounding areas. We take care of school districts, take care of, oil and gas companies. They send all their people to us to get their primary care. And then we have people that are insured, but they don't want to go wait an hour to see their doctor. And so they come because of the experience we give them too. So those are kind of the buckets of people we take care of.
And that's the hardest part to probably sell, I'm assuming. Because we're in that category. Like, we're a member because of the experience and the level of care, right? Like we're insured, we have a low deductible, but we want better care,
right?
And we're willing to spend for better care. What is the most common misconception about your practice or DPCs in general?
Yeah, I think that it's concierge medicine.
The concierge,
and I think the misconception of double paying. Like, I have insurance, why would I do this? It's like,
and that's what everyone always says to me when I refer and bring it up. They're always like, oh, why would I? And they start doing the math, right? They start doing the math like, well, I only went to the doctor like once the last 4 months. And I'm like, well, maybe you should have gone more.
And I think that's a lot of what we do in primary care is preventative health as well. And we are moving it. I hate the term wellness. It's like the worst term of all, because most of it's snake oil.
Why do you hate wellness? You're a doctor, for crying out loud.
I hate the term wellness.
Got it.
Most of it's snake oil is why I hate it.
Sure.
But I think there is an evidence base that even if I'm in my late 30s, early 40s, there are things you should be doing to prepare for your 50s and 60s. And a medical clinic should help you do that. It shouldn't just say, oh, you're mostly healthy, see ya. It's like, well, how can we help you be healthy when you're 60, even though you're 38 now?
So preventative, you prefer preventative, the term, over wellness?
I like evidence-based wellness. That's
wellness.
The term I'm trying to promote. I don't know if I came up with it. I don't know if I've seen it anywhere else. But.
So just evidence-based wellness to avoid snake oils? Is that the...
Yeah. So, I mean, like, people come and they're on like 7 different supplements. And all these supplements have 20 ingredients. And I'm just like, I don't know what these are doing for you. I think there's probably 5 good supplements you can take. And if you bought them at Amazon, they're going to be this price. We can get you them for 30% less.
Can you source creatine?
Yeah.
What do you think of creatine?
There's pretty good evidence for that.
Yeah.
That's one of those things where it's not like life-changing, but it's a little bit of a no-brainer, if that makes sense.
Yeah.
It's not going to, it is a very low risk.
It's not going to cure cancer, but
it's a very low risk of hurting anybody. But as far as like preserving muscle mass as people get older, there may be some cognitive benefits to it. So, I mean, I take that each day. So
yeah. So, but
and you can get it if you want it. You can get it cheaper at our office.
Seriously,
see,
what the heck?
You're even a member, and you don't even know what we do. So, I would say that's the misconception too. Is like people don't even realize the number of things we can do, even when they've been members.
I'm texting Dr. Nick right now. I need creatine.
So those are the types of things of just like. Yeah, being Costco of once you're in here, anything related to your health and wellness, anything you see on TV that's an online advertisement, Antioch does better and cheaper. And people just don't know about it. So all the stupid skincare that's being sold, we have all of those things better and cheaper at our office.
Maybe that should be your advertising.
All the weight loss drugs, we have those better and cheaper at our office. All the anything. So.
That should be advertising as other people's commercials and then just end with like, we got you.
We do that better and cheaper.
We do it better and cheaper every time.
So.
That's awesome. Growth model for you guys and your limitations of growth practically. Like, so you have space, you need doctors. How many patients to a doctor do you allow at Antioch?
We'd like to get full-time physicians up to 600 patients.
Okay.
Traditional fee-for-service, they would have 2,400 on their panel, but they define that as anybody they've seen in the last 3 years. So that's not always, it's not like they're seeing those people 4 times every year. We interact with our patients much more often by text, email, call than a traditional office would. So I kind of say a fee-for-service doctor may have 2,400 patients, but maybe doing 25% of the medical care. We try to do 90% of the medical care on those at least 600 patients. Yeah. 800 would probably be the max for an individual physician with a nurse to take care of. So we have some physicians that are kind of approaching 700, and that's kind of a sweet spot. So.
When is a physician ready for that model? How often can a physician come in? You hire a physician, right? You need another physician. You have too much influx. Like, are they on their own day one? How long does it take for them to learn your systems? And because it's a little different, but it's still just primary care. Yeah,
it doesn't. I would say some of the things are a little bit different, but it's still documenting, ordering meds, ordering labs, ordering imaging. Like you're pushing different buttons in a different system, but learning that system's pretty quick. So we had a physician start in January, and I just met with him yesterday, and he's like, I think I got it after 2 months.
Cool.
And so especially people that have practiced outside of residency before, they pick it up much faster. They're used to being busy and can pick it up. We'd love to be able to fill physicians quickly. So we'd love to be able to fill kind of in 6 months, if that makes sense.
Yeah.
So shooting to get somebody to a full panel, our current newest hires on track for that.
Awesome.
But it is a little bit of a two-sided market. You don't want to go chase a bunch of patients unless you have a doctor lined up. And you don't want to hire a doctor unless you have patients lined up. So it is kind of matching those things.
Yeah, that'd be
as we grow, it allows us to compete on the physician side with the hospital systems because we can guarantee them a salary. We have benefits. We have a 401k. Yeah. We've kind of grown as a business.
You've got cash flow now, so you can kind of hire early.
Right.
Yeah,
right.
That makes sense. That's probably your best investment.
Yeah.
From the business perspective,
finding the right, and our staff is great. So we, Google reviews is probably the main feedback we get, and people always reference our staff. Instead of coming and sitting in a waiting room, you have somebody that who says hi, knows your name,
get you water,
ushers you back, and takes care of you, right?
Yeah, that's great. Breakdown. So, is universal healthcare a good idea?
The words are a good idea.
Right.
Everyone having healthcare is a good idea.
It's all such a mess. It's so complicated.
Everyone having healthcare is a good idea.
Right.
I would say. Well, define more what you mean.
What is it a human right to have health insurance? I think is kind of the best way to start that conversation. You don't have to say anything.
This is totally my personal opinion. So this does not reflect necessarily everyone in Antioch's beliefs. If we're going all the way back to what are rights, I tend to ascribe to the view that most of our inherent rights are negative rights. So people can't do these things to you. Does that make sense?
Mm-hmm. Sure.
So people can't stop you from doing this. People can't stop you from doing this. It's hard for me to say that it's a right for somebody to provide something to you, if that makes sense. Mm-hmm. So there are certainly systems that can make it easier for people to get what they need, but it tends not to be a right for somebody to provide anything specific to you.
Yeah.
That's kind of how I approach that. Now, could we make decisions as individuals and donors and politicians that would make universal health care possible? Yes. Is it the decisions we're currently making? No.
What's your take on that? If that were to work, and the reason I bring this up, it was the most fascinating conversation I've had about the topic. Was a gentleman I know moved to Wichita from the UK, been there his whole life, and I was like, "Well, how's it going?" He'd been here for a year. He's like, "Good." He's like, "Yeah." He's like, "Health insurance is really weird here." That was his first. He's like, can't quite figure it out.
Yeah.
He said, I don't think anyone really knows.
Yeah.
And he did a lot of due diligence, was trying to figure out what to do for his family. And he just had never had to think about it for 42 years.
Right.
Never crossed his brain.
Yeah. So what question do you want me to answer?
Yeah, no, I'm just curious. Does it actually work anywhere else? Is probably the question.
There are lots of things that could work.
Yeah.
So I think the question you're asking is could universal I think you're saying
and still have good care and what are the consequences or
government funded universal care work? Sure, it could work. Is it the best possible system? I don't think so.
Yeah.
I think it tends to work in very homogenous populations. So most of the countries where you see it working well, the Finlands, the Denmarks, the Swedens, 97% of people in those countries are Finnish and Danish and Swedish, right? So in very small homogenous populations where everyone looks like each other,
interesting,
people are fine funding universal things. Our country does not look like that. And so it's much harder with 50 states and 50 different law sets and things to do something on that wide a scale. So could it work? Yes, but it's very hard to implement something like that.
Yeah.
That's
a good take.
No,
you're nailing it.
I'm kind of being a little broad. I'm just saying also,
I want you to offend someone. My goal here is for you to say something that makes someone mad.
But I think Medicare or Medicaid right now. So we think of Medicaid as a government program, but what happens is the federal government funds the state administers the program. The state has no idea on how to run an insurance company. So who do they go to? Do you know who runs Medicaid in Kansas?
No.
So there's Blue Cross United and Centene are the three people that sponsor Medicaid programs. Centene is like the 24th largest company in the United States. You ever heard of them? No. So they made like $100 billion in revenue, I think.
That's it.
Running Medicaid programs.
Wow.
And so when people find that out, and that is not to say like Centene is evil or bad. They make some decisions. I certainly wouldn't. But I don't think people, when people think of that, they think of like, oh, we're all taking care of each other. And that's a great idea. But what practically happens is you fund a system that is interested in extracting money from the system when you have those things.
Yeah.
And so I don't think people would like the outcome if that were done tomorrow. So
and you kind of answered my next question, which is is the system broken by design, or is the system just broken because of those who benefit?
Yeah.
Right. And is it designed to be broken for a specific group of people that are benefiting?
I would change it a little bit. And one of my favorite things to say is no system's broken. The system's working perfectly, right?
There you go.
The system's just designed in a way that doesn't really help physicians or patients is who we think the system's for. But the system's really for the people who currently are extracting money out of the system. So for them, it's working great, right?
Right.
I think the people that have the most leverage to change that are the CFOs and HR people who are making the decisions. So most
of like what entity? Insurance companies?
No, of
hospitals?
businesses.
The businesses.
Of businesses,
Okay.
right?
Oh,
so
customers.
So no insurance company is paying any healthcare funds. So people need to not think about that. All the insurance company is the HR and the CFO has picked that person. That person takes their money and pays healthcare costs and charges a premium for doing it. So all of the care is funded by individuals. It's either funded by taxpayers or it's either funded by employees. It's one of the two.
So you're saying we need to start a movement.
It is the easiest movement to do because you could decide tomorrow. It's the scariest to do because no one wants to mess up healthcare.
Yeah.
Right? But the people that have done it are the ones that are going to like change the healthcare in a community.
Yeah.
Because as soon as the buyers start saying, hey, we want something different, the suppliers say, okay, we're ready. Right.
It's like
but no one will move without the other. If everyone keeps picking the standard insurance, you're going to keep getting the same standard problems.
So DPC, direct primary care, is an example of that, right? That's a small disruption. That's changed how people view health insurance.
Yes. And it's happened because you can, a solo doc can find 600 people to make it work. And I would argue the vast majority of DPCs are people who have just been fed up with the system and I'm leaving. I think Antioch is trying to be, hey, we never were within the system. We are not trying to like conform to the system. We're trying to make a new one that makes the old system obsolete, if that makes sense. So
so expansion DPC, can a DPC get too big? Like if your DPC blows up, is there a point where it just doesn't make sense to not like have another location?
Oh, we have started kind of taking care of some bigger groups that are outside of Wichita. And so through telemedicine right now, we can extend ourselves.
Sure.
But yes, eventually we're going to need locations. My aspirations currently do not go beyond the borders of Kansas.
Sure.
We actually are participating in a grant to try to provide telemedicine or DPC services to rural and uninsured patients right now. So we are trying to, as many people as we can reach with higher quality primary care in Kansas. That's Antioch's reach. So we will eventually have more locations than we do now. So.
Instead of like just making one location bigger, it makes sense to set up like
there are some benefits to having a hub. So we do procedures in our office.
Right.
We have imaging that comes to our office, equipment. So it's nice to be in one sense. And me being next to the hospital to deliver babies is nice. But no, we don't want a mothership. We would like a hub and spoke, if that makes sense.
Yeah. Why are rural hospitals failing and suffering? And I'm going to bring up a specific example, and you can, answer how you want.
First.
El Dorado, our hospital, Susan B. Allen's been on the struggle bus for a while now.
Yeah.
What's your take on why hospitals like that in small communities are struggling?
I mean, hospitals wind up, again, totally my opinion, and I am not an expert in hospital finance, but hospitals wind up being price takers, right? So I have to keep my insurance contracts, and hospitals are paid on a DRG. So if somebody enters the hospital doors, they're admitted and they have
What's DRG stand for?
Yeah, it's a diagnosis-related group.
Okay.
So somebody's admitted to the hospital and they have this problem, right? And that problem determines what the hospital gets paid. If that is Medicare, Medicaid, private insurance, it's all different rates, right? Well, if I'm either not super efficient in the hospital or I can't get people out of the hospital and I have this care that I'm providing that I'm not fully reimbursed for, well, my margins are going to go down, right? And so I think hospitals are stuck in that system of everybody thinks healthcare costs too much. Okay, we're going to lower the prices we pay to providers. Well, you're like cutting off the people who are providing the care in that sense. When a lot of the increase is going to pharmacy benefit managers, traditional carriers, things like that. So I think a lot of hospitals are just being continually squeezed in that I can't charge any more for my services because those things are set. My cost of employing nurses is going way up. My cost of employing physicians is going a little bit up. My fixed costs are rising and my reimbursements are declining. And so and they don't have any options to price differently. Well, that's not true. They don't think they have any options to price differently.
How could they price differently?
I think there is certainly an opportunity for a hospital to go to the CFOs and HR people who are deciding on their insurance and say, hey, we could lower your cost if you pay us differently, right? So that is you see that happening in some places like surgery centers that aren't full service hospitals. Take no insurance, flat prices, contract with large groups to say, send your surgeries to us. We're going to do a high quality job. We're going to charge you this price. There's no surprises. So Surgery Center of Oklahoma opened around 2009. They kind of pioneered that.
And who's paying them? I guess I lost who was in between.
The health plan's paying them.
Okay.
Right.
But it's a negotiated flat rate.
Yeah, they're just skipping the insurance part of paying them. So they're sending them a bill for the total cost of the surgery. They're paying it.
Gotcha.
So if you get a knee replacement at a surgery center in Wichita, it may cost $28,000. If you go to the one major hospital systems, it might cost $72,000.
Gotcha.
The quality is better at the surgery center. So if you're the patient and you're the payer, where would you want to go?
Right.
There. The one thing I guess, I feel like I'm jumping all around.
You're doing great.
The insurance company doesn't have any incentive for price to go down either. And that doesn't make sense to people because you would think that's would be the insurance company's incentive. So I'll ask you a question. So
doesn't make any sense. I can't wait.
So imagine you're Geico, right?
Okay.
And your actuaries come to you and say, hey, we think there are going to be $1 billion, or we think there are going to be $850 million in claims that are going to happen in the state of Kansas. And we think you should charge $1 billion in premium so that you can pay all the claims and then there's this margin to have over.
Right.
Imagine I came up with an innovation that made all the drivers safer and there were only $750 million in claims. What would happen to Geico's profits that year?
They'd go up.
They'd go up. What would happen to the amount they could charge the next year though?
They could charge the same.
Well, they would probably be competed against. Right?
Oh, somebody else.
So somebody else would offer a lower price. The price of insurance would go down.
Across the board, and
Right.
innovation affects all.
Yeah.
Okay.
So imagine the same thing in the healthcare space, though. So in fully insured businesses, there's a term called the BUCAs, so Blue Cross, United, Cigna, Humana, Aetna.
Okay.
I'm going to use that, so I'm not picking one. So a BUCA actuary goes and says, well, we think there are going to be $850 million in medical claims in Kansas this year. So we think you should charge $1 billion in premium so that you're going to pay all your costs, and then there's this premium to have so that we can keep functioning a company. Makes total sense. Well, what if I, as the most awesome primary care doctor ever, make everybody in Kansas healthier, and there are only $750 million in claims? What happens to the profits of that insurance company that year? This is the trick question part.
It's still up, isn't it?
So the law actually says that if that happens, they have to give money back.
Oh, it's regulated.
So it's regulated that there's a medical loss ratio, so they can only make 15%. So if I want to make more money next year as one of the BUCAs, what do I have to do to healthcare costs?
Raise
They have to go up.
healthcare costs.
Yeah. The premiums have to go up. So this is not like when people understand this, it's not a surprise that this is happening. It's a function of the system.
The realization is shocking, but it's not like the fact that that's real is not shocking.
And this came in, it didn't used to be like this. This came in with the ACA, and I think it was well-intentioned, right? We're trying to we don't want people to profiteer off healthcare, right? But what they unknowingly did is created a system where costs have to go up, right?
Yeah.
If me as the insurance company wants to make more the next year, and I can capped at this 15%,
So that
the total price has to go up.
And that makes so much sense why there's fees that make no, like, give me an example of one of the things you guys do that's outrageous at a fee service for fee model. Like, is it x-rays, or you have some services there where it's like a multiple? Like if I get if it goes through insurance.
The CBC is one of those, so that you might get charged $90 for a CBC going through insurance. You may pay $50 if you go to, or $25 if you go to a local just cash pay. We do a CBC at our office for $3.50, right?
Yeah.
And that is not losing money on that. That's just we are contracted with the lab. The lab charges us this. We charge a little bit extra for our nurses' time and the tubes and all these things. So we don't lose money on the CBC, but we are solving a problem for our patients to make our membership valuable.
Right.
We do. And the nice thing is, as we get bigger, we can add more of these types of services. So we got liquid nitrogen in our office. I think we charge $7, $5, $10 an application. It's probably a couple $100 to do at a dermatologist office. Well, we only fill the tank twice a year. We're just charging to cover our costs and a little bit of margin. So
yeah,
medicines are the same way.
It's funny because like everything you're saying about DPC almost sounds like a version of universal healthcare that would work, right? Because like if you work your way backwards, it's kind of like this full circle of like everything you're saying is like, yeah, it'd be great if I could just pay a fair amount every month and then pay just a little cash for everything,
right?
And then make it all work.
So it certainly would work. The people to make those decisions, the people that can most easily make it, CFOs, HR people on the business side, you then have to have legislators change Medicaid and Medicare, but there's no reason that those things can't happen in Medicaid and Medicare. You can use the same concepts we use of kind of the cost plus model in those things. It's just going to take longer in those systems.
Cost plus drugs, the play on words there, right? So it's cost plus what?
They're very transparent about this. So they have acquisition cost of the medicine. They have fill fee from the pharmacist. They have the 15% they charge, and they have shipping, right?
Okay, so they have a 15%.
Our just margins are lower than theirs. That's all it is. But this was a great example. We worked with a small company to change their insurance, and we got insurance companies often for smaller companies will not give you any reporting. Like they won't even tell you what you're spending your money on. They'll just tell you the price is increasing. That would be a great legislative change to mandate that they had to give you full claims data to see what's going on. But we had two high cost medicines, and one of the medications, the plan was being charged $1,500 every month for this person to fill their medication. And I looked into it, and this is a generic medication. It's a chronic medication. It is for a chronically managed condition, and like I said, it wasn't a name brand; it was a generic. So I just looked up how much can we just order this medicine into our office for. What do you think the price was that they were charging $1,500 a month for?
That you got it for?
Yeah, what price did I get it for?
$20 a month.
It was like $100.
So we saved
the company $1,400 on one medication for one person.
One person.
Per month, right? And these are just the games that are being played. No one knows the price of anything, even though the CFO and the HR person are buying insurance. They're price blind. They don't know the price of anything. So somebody tells them the drug's $1,500. They're like, okay, I guess it is, right?
Yeah, you have no idea, and I never really thought about that. An employer has no idea how much money,
and they wouldn't accept that in any other acquisition.
No.
Like in any business, you would never accept like that lack of knowledge and transparency. People just haven't asked that question in healthcare because we assume like, well, I don't know, this worked. One of the Buca plans worked last year. I assume it'll work this year. I guess we're going to renew, right?
Yeah.
But the only way it's going to change if people make different decisions than they're currently making. So,
what are you most proud of at Antioch and your DPC model you've built?
Oh man, I'm a person that tends to be more dissatisfied than proud.
Yeah.
No, I think the fact that people walk in and just realize this is totally different than any other healthcare experience, that they're there and cared for, and that people care about them. That is the culture of our practice, and so. Yeah, we're just way different than any other experience where, oh, you come check in, okay, sit down, fill out this paperwork, we'll call you in 45 minutes. You're treated like a human at our office.
Yeah,
and I think that's just way
cattle.
different. Yeah.
That's what I always say to people. I hate to say that out loud in front of service fee model people that I know.
And again,
but it's like
I've said things about brokers. I've said things about insurance companies. I've said things about hospitals. They're just all playing the game.
Right.
They're not, they might not even like this game, but they're
No.
playing it to the best of their abilities. I've just been always like, why don't we just play a different game than that? And people can choose to do that. It just, they have to think a little bit more deeply. And we're getting to the point where it's costing so much that we're seeing this happen. People are saying like, we got to do something different.
Yeah.
So,
Yeah, it'll be interesting. What do you think this will all look like in 5? Do you think in 5 years there's going to be another big change? 10 years?
We'll either have universal healthcare or we'll find a solution that works better than what we currently have.
What time frame you think?
5 to 10 years.
Really?
One of those two things will happen. Yeah. There'll either be a revolution and people will decide like we're not putting up with this anymore and we're going to do this ourselves, or there will be some version of universal healthcare.
How's technology and maybe specifically AI is what I'd like to ask in the medical field. Like, what are you seeing?
It's been a great tool. We use a HIPAA compliant AI called Open Evidence for our practice.
I've heard of that.
And it is like having a consult on every patient. So it doesn't just help us write our notes. It actually goes in and says like, you should think about this. And here's a test you could consider ordering. It is like an adjunct to the thinking. So it is not replacing our thinking. It's like having a couple of other doctors looking over your shoulder and saying, don't forget about this and make sure they get this screening and do these things. So we've implemented that in the last year and it's extremely helpful. It's making our doctors more efficient and because we have time, we miss a lot less than normal people, but now we're missing even less.
Sure. Are you recording? How does it take notes on interactions?
Audio.
It's audio.
So
gotcha.
Recording goes into the HIPAA compliant platform, generates the notes to document, and then it is not yet integrated enough to like do the tasks, but it's creating the summary. Yeah.
So it creates summary, creates recommendations, but it doesn't go past that point.
Not currently.
Do you see it's going to go past that point?
Yeah, it would have to be more. Right now, this is a separate tool that we're using, and then connecting back to our EMR. Integrated AI tools into the EMR can start doing some of the things while we're talking. Oh, we're going to get this lab on you and the lab's ordered, right? That will eventually be happening. So,
yeah, that makes sense. That's wild. Yeah, I'm going to prescribe you this. Do you want to pick it up here or there? Right. And then by the time the doctor walks out of the office, it's already done.
Yep.
Yeah, I believe that, dude. It's all moving fast. Dude, you're awesome. Thank you. This was fun.
Yeah.
I've learned a ton. My brain's exploding about their 15% and they benefit by everything going higher.
Again, I give this talk to residents and I try to emphasize like, I don't really think there are any villains. Like no one's trying to be evil. It's just the outcomes seem evil at the end of the day. So,
and I mean, that's just the nature of capitalism too. Like when it infiltrates all these other, like there's somebody leveraging something to make a lot of money in every industry.
Yeah.
Right? Like,
you just got to set up the rules of the game better.
Right.
So that's what we're trying to do. So I think capitalism's not in and of itself bad. It's like you can't give a crappy set of rules to capitalism because then you get really crappy outcomes. So,
Yeah, that's good. Well, we've been at Antioch for 8 years and the culture and the treatment and everything keeps us coming back. And that's the thing that I want to stress for anybody listening. DPC as a model, like you do have to experience it to fully understand it. I don't think there'll ever be a perfect message or, for a while, I think over time, it's just like anything, bad news travels faster than good news. So the more the system breaks, the more you're and DPC models are going to be talked about. But I do think I encourage everybody to look into it, visit a DPC clinic. If you're in the area, obviously check out Antioch.
Yeah. Anything you see on TV, we can do better.
We'll
get you your creatine. So
I like it. No, I'm on it. So thanks, dude. Appreciate it.
Thanks.